Good afternoon, everybody. It's what do we got now? Two after, so we'll get started. Welcome to January office hours. Wanted to thank everybody for joining today. We'll have more people hopping on, I'm sure, but we'll get it going. Want to make sure everybody can hear me okay and see the screen. So if I could just get a yes or a hi or a yeah, I got a yes. Okay, great. Thank you. Chat functions there for folks. I see that it's going on as well. As always, we're recording, so if anybody wants to access this after the fact, they can do so on our website. And questions along the way, please feel free to stop, ask, comment. Chat functions there as well for that. And we know the drill. So we'll get forward and we'll start into this month. We've got a lot of stuff this month to go through since we didn't really meet uh, and have the ability to get together in December outside of that special office hours.
Hey
Um,
Travis,
yes.
it's Jessica. We're getting a lot of reports that staff are being asked for a password to get into the meeting. So we're missing quite a few people.
Okay. Um,
Um, just looking
Yeah,
at the
Jess,
invite.
I was gonna say, is there anybody able to pull the invite up and see if there's a password that's
there
being?
is. Yeah, there is. So Jess, if people are emailing, if you look at the underneath kind of where it says, mine said start meeting, it didn't say join meeting, which was odd. But I could just copy the password that's underneath that and drop it in, and that allowed me to get in.
Yeah, I don't have a password on my invite.
People
I
are
need to
putting
be
it
able to
in
get
chat
in.
right now. Right now, there's a bunch that are putting it into the chat as well.
Okay, I will get that out to everybody.
Yeah.
Thank
So, well,
you.
Jessica's going to email that. That's a password that's being put into the chat right now for folks. Thank you, Jess.
Mm-hmm.
Well, that's odd because we set the meeting up just like we always have in the past. So I'm sorry that that did that to folks. We'll have to look at that next time. Thanks, Jared, for pointing that out. We'll make a point to look at that.
Travis, you may need to do it because when I do it, it won't let me reply all to the invite.
Well, I'm not in my email right now, so I don't know if I'm able to do that.
Okay.
Um, I'm in slideshow function.
Okay, hang on one second and let me just draft a separate email to out to people.
Are you able to copy the original out message to the folks that it went out to and just copy paste?
No, it will not let
No,
me.
it won't.
I will email my supervisor list right now.
All right, great way to start off.
I'm getting feedback that the password I sent to my people isn't working. Wow.
Okay, I just sent it out to the supervisors list.
Oh, well, let's see. People are starting to come on. See if give it another couple minutes, see if more can come on because we're up to 41 right now. I was wondering why it was lower than normal when we first started off.
Yeah, that would be why.
Yeah.
Can you transfer me permissions and I can get started. And then you can, this way you can check to see if there is a password in that invite, Travis. But I don't know, it doesn't say take over, so I don't know if I'm a co-host.
You should be a co-host. Let me see.
I'm not seeing the button that says take control.
We got people still coming on. Hold on a sec. Jessica.
Liz just said that it was sent with the agenda. For some reason, the password is embedded in that email. All right, looks like people are coming in.
That's odd. Followed the same process we always have. That's so odd. Huh. Okay. Well, we're getting up there in numbers now, so folks must be being successful. Jessica, you're a co-host now.
Okay. It's not letting me accept to drive the deck. So that's awesome. All right, that's not working. Let me try it this way.
There you go. Now you got it.
Okay.
Yeah,
No,
you may
it
have
won't let
to.
me.
You may have to. Unless I have to do it still. Yeah, I can
It's not
still let
yet.
people in.
All right, it's not letting me advance the deck though. Okay. I'm gonna send it back to you and then we can just get started.
Okay. All right. Well, let's start over. All right.
Redo.
Yes. We are at 65 folks that have gotten on. Our apologies for the technical difficulties. But can folks see the screen okay? Can they hear me?
Yes.
Can-
Yes.
Okay. All right.
Yes.
All right. We're going to get started. For those of you that are having trouble getting on, we're sorry. We'll work on that moving forward. But I don't know why that password thing came on like that, but we'll get that fixed moving forward. We're going to get started. This is being recorded as always, so it'll be available on the website in the coming days. Questions as always along the way, please stop and ask us, or if you have anything in the chat you want to put in, please do so. But we have a pretty heavy agenda this month because we didn't really meet last month outside of the special policy review that we had to go through. So we're going to start and get moving here. And we're going to have policy procedure updates, some quality performance and compliance review, children's updates, redesignation review that we have to go over from our enhanced oversight plan that we had from our redesignation last fall, and then some other miscellaneous topics that we have to touch upon. So with that, I'm going to turn it to Jessica to start touching on some of the policy stuff.
All right. So I usually talk fast, but now we're getting a late start and we do have a full agenda today. So today I'm going to review non-health home policy, the NOD policy. This is just going to be a minor tweak from that 12/9 special office hours that we had, Planacare adults, Planacare children. And then some upcoming policies in the coming months is going to be our CANS policy, our core service requirements and billing policy for children, HCBS environmental modifications, vehicle modifications, and advanced technology. Initiating and maintaining level of care for OPWDD members, outreach and engagement. Our quality policy is going to be having an update in a new transfer policy. So those will all be coming down in the coming months. You can go to the next slide. So the first policy we have is just our non-health home policy for those folks that are on the call that serve a non-health home population in NetSmart. No changes to this. It was just an annual review. If anyone has any questions, feel free to unmute yourself and ask. I do have Courtney on the line who will be able to cover any questions that you may have.
Courtney, was there anything you wanted to note to that, the population of folks that are working with non-health home enrolled members?
Maybe she also can't get it.
Maybe. All
It's okay. You can go to the next slide.
right.
All right, notice the decision in fair hearing. So nothing has changed really since we sent this out in December and we did our special office hours in December on this. So again, I reviewed in detail all of that. This was particularly updated because at the time when we had the policy, there was still one pending component. So as you could see, if you look through the old version of the policy, it said this section will be coming. And that was because we were waiting for something in MAP to be updated with their next release. So that has happened. So now we have that MAP update that allows us to do some functionality in MAP when we have members who have requested a fair hearing. And this is particular to our members who have requested a fair hearing and then have requested aid to continue during that fair hearing process. You can go to the next slide, Travis. So if you are in NetSmart and if it is known to you prior to you disenrolling a member that they have requested a fair hearing and they have requested aid to continue, then you're going to pend for aid to continue in NetSmart. So if you have a member who requests a fair hearing, they request aid to continue, and you are made aware of that before you close that person in NetSmart, there will be a pend for aid to continue function. And this will be in the contact notes, just like you pend someone for excluded setting, you pend them for diligent search, there will be a pend reason added for aid to continue. If the segment has already been closed, the health home will work with DOH to add this pend segment. And either you will continue to that work with that member or that member will be reassigned to another CMA. But this is a feature that will only be used for our members that we are made aware of. And it's been confirmed by OTDA that they have requested a fair hearing, requested aid to continue, and their segment has not been closed yet. If the segment has been closed, nothing will change for you guys. We will work with DOH to get that pen segment up and running in MAP. You guys would just continue with your work with that member. You can go to the next slide. So during that fair hearing process, if the member, quote unquote, wins their fair hearing, or the favor is in the member's favor, so what will happen then is that DOH will go in and pend that segment for approved for fair hearing and notify AHI. So we'll get notification that that member has won their fair hearing. we'll know because we'll be at the fair hearing. And then what will happen is that DOH will put a pen segment on, pended for approved fair hearing. And then what we have to do is we will then the first of the following month, we will open an enrollment segment for that member. So let's say you're serving a member. Today is the date that we get notice that that member has won their fair hearing. DOH has put them in pended for approved fair hearing. What will happen on 2/1 is Courtney will ensure that that segment has been switched over to an enrolled segment for that member. If the outcome is not in favor of the member, so let's say they go through the fair hearing process, they have aid to continue, they lose their fair hearing, DOH will put on a code that says pended for denied fair hearing. And then what will happen in this case is that AHI will work with the CMA to disenroll that member by the last day of the following month. So let's say today is the date of the fair hearing. We discover it is, they have lost the fair hearing. DOH puts pended for denied fair hearing. We will work with whatever CMA is assigned to have that member closed out by 2/28. Does anybody have any questions on that? This functionality is probably only going to be raised or used when the time comes when you have somebody. And for most purposes on slide 6, when we discussed using that pend function that's being added to NetSmart, most often you are not going to know that the member has filed a fair hearing or has requested aid to continue prior to closing out the segment. So it will be very, very rarely used. All right, we can move to the next slide. If you guys have any questions on that, you can let us know. Plan of Care adults. So this was updated because it was due for an annual update. Or it was not an annual update. I'm sorry. This was updated because we got an updated policy from the Department of Health for our plans of care. So we've added a couple of definitions in our policy. So you want to go through and look through that. We've added and clarified some definitions in there. There has been an emphasis placed on care team involvement when developing a plan of care. This is something that we see very often on the children's side, that the whole care team is involved in developing that plan of care. They have now put language in the adult plan of care policy that they would really like care managers to be coordinating with the members' care team. That's not new. We should have always been doing that. But what they really want to see is collaboration on the building of the plan of care and then sharing of that plan of care with that members' care team. It could be in cases very, very limited, or you could be working with a lot of different providers that you're now including in that plan of care development as appropriate. And then it also does point out specific language about every single month a care manager should be addressing at least one goal that is outlined in that plan of care. So we typically, and then when we audit, what we look for is a care manager note to be in there every month. That kind of shows us that you are addressing something in the plan of care. This is something that's already been in practice by everybody, but now DOH has really put definitive language in the plan of care that that's what they will be looking for as they move forward when they audit, to ensure that we are addressing at least one goal that is in their plan of care. You can go to the next slide. So another thing that they've included in their plan of care update is that we're including the appropriateness criteria from our eligibility screen, and they're looking to see if that was incorporated into the plan of care. So if someone's appropriate for health home because they have homelessness or they have high utilization, this is something that they're looking to be worked on in their POC and addressed. Again, this has been in practice at AHI for a while now, so it should not be changed to your workflow. It's already something that we look for, but now they have put specific language and policy. Something else that they're focused on and they're specifically pointing out is that if you're working with any member that is enrolled in health home and they have a diagnosis of HIV or AIDS, there is a requirement to have a team meeting every 6 months. That's not a new requirement. That's always been the case. But they have found through their auditing that that's not happening in the frequency that it should be. They don't have to be enrolled in Health Home Plus for HIV or AIDS. It's any member enrolled in Health Home with a diagnosis of HIV or AIDS. So you want to make sure that you're having a team meeting every 6 months. We have a form in the bottom left-hand screen of NetSmart. It's called the Interdisciplinary Team Meeting Form. That form can be used to record these meetings. So if you are working with a member, in the bottom left-hand corner of your NetSmart screen, when you have a care team meeting, you can utilize that form to record that you've had a meeting. And again, we'll be looking for those to be happening every 6 months. And we will touch on this again as we get into later in the slide deck when we review some of our work around the EOP for redesignation. Next, plan of care completed within 56 days. Again, we've been doing this for a while, but they really point out that the plan of care needs to be done within 56 days annually or as needed. And they're calling as needed, I have it in parentheses there, a significant life event. So if anything comes up and there's a change, they point out a significant life event will require an amendment. In all cases, we will require that a plan of care be signed. So an initial and then any amendment, and every amended care plan, initial and amended care plan is exported to MAP. So they did point that out, that every POC that you do, we do extract from the system and we do upload that into MAP. And then lastly, on the adult side, if there is a SIN change for any reason for any of your members, please reach out to the Health Home immediately. There are some things systematically that Courtney needs to do to make sure that the SIN number matches the member. There have been billing issues and plans of care blocked. Do you think you're doing the plan of care? Do you think it's getting uploaded? Do you think you can bill? But then there was some sort of issue where it blocked that plan of care from uploading into MAP because the SINs did not match. So please make sure you're reaching out to Courtney as soon as possible. Does anybody have any questions on the adult plan of care changes? Okay, you can go to the next slide. So now we're going to move into the children's plan of care. Again, this was updated because we had a plan of care update from DOH. So what they did for interdisciplinary team meetings, they've actually updated the definition of interdisciplinary team meeting. A lot of people use multidisciplinary team meeting. DOH has now defined for us that interdisciplinary team meeting, multiple disciplinary team meeting, child and family treatment team meeting. If for those high fidelity RAP providers out there, they're all one and the same. All those terms can be used interchangeably. So those definitions have been clarified. Again, they've added language outlining that every single month the care manager needs to be working on at least one goal that's in the plan of care. Again, historically, we've always done this through those care manager notes. It shows that you're working on the plan of care. This is something that's been in practice for us since 2019. So it should not be a shock, but now there is prescribed language in the plan of care. You can go to the next slide. For kiddos, they're really looking for the needs from assessments to be incorporated into the plan of care. So that's going to be needs from the comp, needs from the CANS. They're really looking to have those incorporated into the plan of care. Again, adding language around that. That language has always existed in AHI policy. And again, it's something that you guys already do. The other thing that they added, and this is particularly to our high fidelity RAP children that we have right now, that the care team and the child and family treatment team meetings, those play a central role in POC development. So that is for continuous oversight of that high fidelity RAP population. The other thing they added was the appropriateness criteria addressed in the plan of care. So just like on the adult side, they're looking to have what makes someone eligible and appropriate addressed in the plan of care. They're looking for that in our work with our kiddos, that they are eligible and appropriate, what makes them eligible and appropriate, and making sure that that's included in their plan of care. As far as time frames go, the general population of children, you have to have an initial within 56 days. That's the same on the adult side. There are two outliers to this, and that's going to be if you accept a referral for a kiddo that is HCBS and they have an active level of care. When you accept them, you have 30 days to get a plan of care done. And if you're working with a high fidelity wrap kiddo, it is 45 days. So you just want to be cognizant of those timeframes if you're working with one of those other populations. Clarified language around members 10 and older should be signing their plan of care, as well as the parent. If the kiddo is, you're working with a 14-year-old and they refuse to sign their plan of care, that's fine. It can have just the parent signature on it, but you just want to note in a note, hey, I asked little Johnny to sign his plan of care. He refused. Mom has signed the plan of care. So that's not something new. We've been doing that for a little while now, but they have added clarifying language in there on making sure that if a kid that is 10 and older has refused to sign the plan of care, that we have a note in there. The next two bullets are not new, just reminders, because they are something that we frequently see missing in our plan of care. And that's for youth who are 14 or older or 17 or older, really having goals related to independent living or goals related to transition to adulthood. And those can really be pulled from the CANs. So really incorporating those into your plan of care. And then lastly, just like the adult side, if there's ever a SIN change, please make sure that you're reaching out to the health phone so we can get that corrected. Does anybody have any question on or questions surrounding the plan of care updates for children? All right, I'm going to punt it over to Taylor.
Thanks, Jess. Can everybody hear me okay?
Yes.
Okay,
Yep.
perfect. Thank you. Okay, so very exciting news. I know this has been a topic of discussion for quite a while now, but we are ready to move forward with adding gaps in care into NetSmart. So starting in February of 2025, so a few days, we will be uploading gaps in care that we receive from our MCOs into NetSmart. There will be a more comprehensive training scheduled for about mid-February. We just want to get a couple of those gap lists from the MCOs uploaded in there. That way everybody has something to look at and reference when we're moving through the training. But today I'll just kind of very high level go over, where things are going to be, kind of what it's going to look like. And then again, I will send out an invite probably before the end of the week for something in mid-February that will also be recorded for reference moving forward. And I will also be sending out an email to supervisors for the first couple of months that we're moving from sending you guys like the hard copies that come directly from the MCOs to moving forward with this integration to NetSmart. Supervisors will get an email alert from me just letting them know, hey, this has been uploaded into NetSmart. But Travis, if you want to go to the next slide, I will show you guys where you're going to actually access the gaps in care once you get some in there and you can see them for yourself. So similarly to how the dashboards and work lists have worked for the CES draft tools, this is going to be similar for the gaps in care. So care managers will just see the gaps for their specific members. Supervisors will see gaps in care for their entire agency. And you'll access this through the work list. So you'll see this screenshot of NetSmart. You guys will toggle over to that center tab that says work list. That is where you go right now to see your draft CES tools. You'll have a new dashboard in there that is for gaps in care. You guys won't have anything uploaded in there right now. But again, I will send out an email once that has been uploaded in there. That way you guys can check it out prior to the training. Our workflow is going to be that supervisors and care managers will be able to see the open and in progress gaps in care for their members on these respective work lists. Again, I will send out an email. That way you guys will know when to look in there and check it out. Yes, it will be for both adults and children. Travis, you can go to the next slide. Okay, so navigating to the gaps in care. So on the previous slide in that work list, you guys will see like SIN number, name, all of that good stuff, the name of the gap. If you click on the SIN number directly on that work list, it'll take you right to that member's face sheet. And then you can toggle to their gaps in care on the left-hand side. You guys have probably noticed that there has been that gaps in care tab on the left for a little bit now as we've been testing and figuring out the workflow. Once you guys have gaps in there, that's where you'll actually go to see those. and kind of toggle through and adjust the gaps in care as needed. Next slide, Travis. So once you click on that gaps in care on the left-hand side, you'll be able to see all the gaps in care that are assigned for that particular member. Again, we will go over this during the training, but then the care manager will be responsible for going in and updating the gap in care to reflect the status. So you'll be able to select open, in progress, deferred, things of that nature, where we will be able to track those things and send them back to the MCOs. I know there's been a lot of feedback that I get back and forth from care managers and supervisors like, hey, this gap has actually been closed. It hasn't been open for some time now. That is all good information. We'll now kind of have it in a streamlined fashion with everything in NetSmart, where I can pull this data out and send it to the MCOs and let them know, that that gap has already been taken care of, and let them know to hopefully better their workflows as well. Next slide, Travis. And then the last very high level thing that I'll touch on today is that there will be a tracker in DataDen for you guys. You'll just be able to access it, as normal. You'll navigate to the gap in care report from the main navigation page. It is not in there yet, but I will turn it on once I upload the gaps in care. That way you guys can, again, familiarize yourself with this before the training. That way you guys can come with any questions you may have. But on the report, you'll be able to sort the gaps in care by measures, MCOs, and their status, as well as view any comments that have been entered into the free text box. So again, this is a very high level summary. I will be sending out an invite for that training that will be recorded. And then if there is a need for another training, if it's too short notice and a bunch of folks can't make it, I'm more than happy to do an additional training towards the end of February as well. But I just wanted to let everybody know this very long time coming project, will be happening fairly soon. So get excited and I will send everybody out that invite by the end of the week. Thank you, Travis.
Great. Thanks, Taylor. We're looking forward to this. We've been talking about this for well over a year, and it's been a lot of moving parts. So we're really excited for this to come together finally. And we hope it's going to help you all as well as far as streamlining processes on your end. And, it's just going to make for a much more robust system for reporting for everybody all the way around, and, better quality data. And just, it's going to help at the end of the day for reporting for measures and better quality care for people at the end of the day. So we're looking forward to getting this going and getting good outcomes as a result. So yay. Thanks, Taylor. All right, we're moving on. Jessica, you're back.
All right. Unfortunately for you all, I'll be talking for a while. So children's updates, I just got one slide today for you guys. Update, just a reminder that the updated CANS training goes live for 2/1. That's going to be that new format. That's going to be, you need to take the booster training for your recertification. You have to be certified on 0 to 5 and to 6 to 21. It cannot be one or the other. They are now 2 separate certifications, and you have to take both to be fully certified. Also, if you have new staff starting, they have to take the intro training before they can take the booster training. There are some of our current staff that have not taken the intro training, so you're not going to be able to sign up for the booster training. I did get a list from the CANS Institute, and I did send that out to everybody, so just keep that in mind as you go through your trainings. If you have been, I almost said olds, but then I'm also in that category. If you have been in care management for a very, very long time, at one point you were grandfathered into not having to take that intro training. But people like me who have been doing this for over a decade, unfortunately, they have had to make that required in order to go with this new training format. So we all have to go back and do that intro training. But if you fell into that bucket and they couldn't find something, they did go through paper certifications as well to get you in. I did send that list out. Raquel, did you have a question?
Yes, I did. So I just lost my train of thought. I'll put it in the chat.
Okay, that sounds good.
Thanks.
Yep. Okay, so moving on to the updated CANS algorithm. As if we didn't have enough going on, I know I've been talking about this for a very long time. Here we are. We have had an update to the CANS algorithm. You know, they went with that CANS 2.0 logic back in November of 2023. What they heard, and they received a lot of feedback from all of us, is that we did not think that the algorithm on the CANS 2.0 really matched the acuity of our members, and kids were coming out lower than we would have anticipated for acuity. They reran the algorithm on all of those kiddos, and we got sent a file. I distributed that about, I want to say last Monday, maybe even the week before. So any of your kiddos that were affected by that acuity change are going to be on that list. What we had to then do is that also affected your billing rate. So that means since November of 2023, potentially you have been receiving a lower billing rate than you were actually entitled to. So Courtney had put together those spreadsheets that crosswalks that member, the months that those HMOs that were submitted for potentially at a lower rate. What we needed everyone to go in and verify that, what we needed is everyone to go in and verify that they did deliver services per that member's updated acuity. So if your member came out low and you only delivered services that met the low acuity, you would not be able to bill for the higher rate. But let's say you had a kiddo who came out as a low, this is old language, and then we found out that they're actually a high, but you've been meeting with that kiddo, you know, 2 core services a month and 1 face-to-face, you can then go back and bill for those services. Most of our kids went from medium to high. A couple of them went low to medium or high, but most of them are coming out in that middle category and then bumped up to a high acuity. So we're just asking you to look at those spreadsheets, return them back to Courtney by 2/21. That's going to tell us exactly what adjustments we need to do to recoup some of that lost billing for you guys. Does anybody have any questions on the updated CANS algorithm? April, you are going to, so she's asking how far back do we go? That is going to be on that spreadsheet that Courtney gave you. She gave you the dates. It goes back as far as November of 2023, but let's say you didn't enroll somebody until January of 2024, your start date will be 2024. But she, in those spreadsheets, gave you the exact kiddo and the exact month that you need to check for.
Jessica Raquel had her question for you lined out.
So 2-day training is confusing on times. Is it all day, both days, or just? It is not an all-day training. I don't know what your training you're referring to. There's a couple of different ones, Raquel, but none of them are that you should be asked to attend are all-day trainings. The booster training is just a half-day training. The CANS intro training is just a half-day training, and the prerequisite for one of the trainings is that person-centered plan of care training, and that's also not all day. But correct me if I'm wrong on that. Tanya, you have a question?
Yeah, sorry. So to the algorithms, we have a member who was initially at a standard acuity. Since having it looked at again, he was deemed at a complex. So we went back to see if we are able to provide those services for the new billing. However, the care manager had to do an updated CANS actually today and was deemed a standard acuity again rather than complex. So does that care manager continue to treat at the complex since that's what was deemed?
Can you please email me that person? Because the CANS, so the other thing to this is the CANS algorithm has not changed in the UAS. The CANS 2.0 algorithm is still going on. The complex, that member should still be flagged as complex in MAP. So if you look in the UAS, it's still going to have the previous aired 2.0 outcome, but if you look in MAP will have the updated correct complexity. So if you could just email me that, member Tanya, just so I can verify in MAP that that's still correct and that you're getting the correct rate from today moving forward.
Okay, I will. Thank you.
Yeah, you're welcome. We have to wait for the next UAS update release to have this actually corrected. So that's what we're waiting on. So this first batch of billing is going to go through, and then there's going to be a couple of months. I think it's January, February, March. We're gonna have to go back and rebill, but then come March of 2025 moving forward, the algorithm will be corrected. And just to go back to Raquel, I registered for March 5th, and I'm not sure what we had to take. Raquel, if you just want to send me that in an email, I can just verify that that's actually what you're supposed to be taking. I mean, I'm sure it's not going to hurt to retake it, but you may not have to take both days. So moving over to LOC billing, Millen has added the rate code to go back to those LOCs. So as everybody knows, HCPS came into Health Home April 1st of 2019. Everyone is doing level of cares on their kiddos. We had something that went into effect that now allowed us to bill for those level of cares. However, it was several years late in getting approved, so they're going to allow some retro billing. So going back to 4/1 of 2021, if you've completed a level of care up until October of 2024, we sent that list out to you. Millen has added the rate code. Courtney is working on getting all of those level of cares billed out. So you can see some backed billing there for those level of cares from October 2024 on. Those are going to be billed out just like a CANS would, and you would receive payment just like you currently do for your CANS. So it's going to be that backed level of care billing that we're looking on. Courtney is working on getting those in the system. We have to get a rejection. They're all going to reject. Once we have that rejection from Millen, Courtney is then going to send a spreadsheet to the Department of Health, and then they will issue payment that way. So that is underway. So more to come on that. Did anybody have any questions on that though? And just a reminder, your level of care had to be completed on time in order to receive payment. So if your LOC was over 365 days, you will not get paid for that level of care. All right. And then just lastly, just a reminder for High Fidelity Wrap folks that are out there, the new core services, those went into effect this month for High Fidelity Wrap. The OMH guidance on those kiddos supersedes the 4/1/2025 implementation date. So just a reminder out there, I did email out to those CMAs so they had an awareness. I did not see the memo from OMH. I was told that a memo was distributed by OMH, so I just wanted to follow that up with a confirmation. Also for our High Fidelity Wrap folks out there, there are forms that are built. They're being pushed to production. I've let NetSmart know that we're good to push those to production. That will help with the duplication of documentation for these kids. Once that happens, you will no longer have to do the duplication of documentation. Everything will be in NetSmart that you need, and then we will allow direct access to OMH to those kids right in NetSmart. There also was a rate increase for our High Fidelity Wrap kiddos. We are working on an updated CBQ to get that in place. Once that is in effect, we will rebill out all of your 2024 claims for all of your closed members and your active members. And then once the new CBQ is in place, you will move forward with the new rate that way. Does anybody have any questions on that?
Jessica, I have a question that's not exactly on that, but it has
Sure.
to do with good stuff, and I just want clarification and figured maybe somebody else did too. So I know that at one point we had talked about the safety plans, and
Yes.
it was said that if we get a safety plan from a provider, their therapist or whatever, that we can upload that, and that way, and then we don't have to do the one that's in NetSmart. how do you want that documented? Like, I just want to know exactly what we need to do so that people are aware that it's there. If there's not, if that assessment is not done in NetSmart, does that make sense?
Yes, it does. So
Okay.
that is on our roadmap for 2025. That has not been approved yet. So right
Okay.
now, we still have to be doing the NetSmart Safety and Crisis Plan. We have asked for a policy modification from the Department of Health to not duplicate work. So that would be an example that if there is a safety and crisis plan that was created with a clinician, as long as it's uploaded within the last 12 months, then you would not need to complete the one that is in NetSmart because that would just be a duplication. However, we're waiting on clarification and an update in policy to allow that, but we have asked the Department of Health for that allowance. I just don't have anything in writing yet.
Great, thank you.
Sorry, I did not have better news.
Nope, that's okay. At least I knew we talked about it and I was like, I didn't remember that part, but I got it. Thank you.
Yeah, no problem. I was hoping that that would have been included in the plan of care update that we received. However, it was not.
This is not fake news, right?
Not fake news.
Not fake news.
But yes, I am anticipating that change and I will let everybody know as soon as I do. All right, any other questions on kiddos? All right. All right, so moving into our redesignation from 2024, coming out of redesignation, as you all know, we did very, very well on the adult side. We're anticipating sometime this spring for our kids. That's when our due date is. If DOH is running on time, that's when we will have our kids redesignation. But for our adults, even though we did very, very well, we do have an enhanced oversight plan, performance improvement plan, whatever you want to call it. So there are areas that we do need to focus on moving into 2025 to just do a better job in these areas. So I'm just going to walk through a couple of things that they noted on our EOP that we're going to be focusing on and really looking to see some improvements in our audits in these areas. So one of those, as promised from earlier, is our HIV population. So as you know, when you work through your comprehensive assessment, we have a section on there about HIV. So all of our members, age depending, it may be appropriate, it may not be appropriate. We really need to be working with our members on asking them if they would like to receive education on HIV, offering them testing and prevention treatments such as PrEP. So that is something that we are going to be looking for. It is on our current audit. We are going to be continuously auditing for that. So all members, whether they're enrolled for HIV or AIDS or not, we need to have a focus on education, testing, and prevention. And just by answering the questions on our comprehensive assessment, you will fulfill that requirement. Just to note, that is a newer required section on our comprehensive assessment. So some of the comps that were pulled did predate that required asterisk on there. So moving forward, that should not be a problem. The other thing, as I spoke about earlier when we went over the plan of cares, is that if you are working with a member who is HIV or AIDS, that may not be the number one reason they're enrolled. They may not be part of the HIV AIDS Health Home Plus population. Any member, they have to have a care team meeting every 6 months. And you're again going to document that in the bottom left-hand corner in NetSmart in the interdisciplinary team meeting form. Now, if the member is Health Home Plus for HIV and they become disengaged, the member has to be put into diligent search and you have to complete diligent search efforts. We like to see all of our members moved into diligent search if it's not in their normal pattern of behavior to become disengaged, but especially for this population, this is an outlier. They have to be put into diligent search, much like our AOT population. So those are some updates on that population of people that we work with and some feedback that we received from the Department of Health. They are specifically looking at us to grow in those areas. Secondly, a major focus in the area of our audit where we lost the most points was in our comprehensive assessment. We do allow you to complete the comprehensive assessment to the best of your professional judgment. We do not require every single question to be asked and answered, only those with a red asterisk. However, it's important that your sections have at least some information in them. If applicable, we've seen a lot of very bare bones comprehensive assessments. So that leads to areas just completely not being addressed. Another area where we were really pointed out and deficient is that if there's a need from a comprehensive assessment, it has to be incorporated into the plan of care. So if you're showing me that there is a need in the substance use section, that member is engaged in substance use activities, that member doesn't go to, let's say, outpatient treatment, but they want to, that has to be incorporated into the plan of care. Now, let's say that member is a user of substances, but absolutely does not want any help whatsoever, does not want it on their plan of care. What you need to do is make sure that you have a note corresponding to the date that that comprehensive assessment was done, indicating that yes, you as the care manager know that your member has a substance use issue, but they are unwilling to address it at this time. And that's why it's not in that plan of care. So really, really important as you walk through the tabs on that comprehensive assessment that you're completing it to the best of your professional judgment. And if there is a need, that it's either being carried over or noted in the record as to why it's not in the plan of care. Does anybody have any questions on that piece? All right, you go the next slide. Oh, sorry.
I just wanted to note that one of the main pieces of feedback was a lot of the assessments were incomplete, not incomplete sections, meaning nothing was there. So we have to do a better job as a network to put more effort to have more complete assessments. So you'll see us as a lead focusing on that more. So don't be shocked when we start pushing on that area through our audits. Because we've done well everywhere else. So we have to focus to improve. So this is an area we're going to improve on.
All right, you can go to the next slide. Okay, lastly, something that we're going to touch on from our EOP would be disenrollment. This has been a huge area of focus for us these last 12 months. Again, we were audited going back 3 years. But this last year, we've really put a focus on that. It's super, super important that when we're disenrolling members, regardless of the reason. So reason aside, we should always be issuing them a disenrollment letter with why they're being disenrolled, the date that they're being disenrolled, and how to re-enroll in the program. There are some instances where we have members that go incarcerated or who are homeless and don't have an address for you to mail it to, or their address is DSS or their address is a shelter. You have to have a copy of that letter in the member's record, and you have to issue it somewhere, the most appropriate location, the last known address. That letter has to go out. There is a sample letter in our disenrollment policy. You can use that and just plug in your own agency information. The other thing that we need to focus on is, again, if a member disenrolls from us, regardless of the meeting, the care team needs to be notified that the member has been disenrolled from Health Home Services. Internally, we have a letter that we send out to care team members, just notifying them, and we upload a copy of that into the member's record. If you'd like a copy of that letter, please reach out. I can have Hannah get that over to you. So either through email, calling them, sending them a letter, the care team does need to be notified of that member's discharge. And these two apply to adults and to kids. This was specifically an adult audit, but these two elements do apply to both populations. Does anybody have any questions on that? All right. So moving into our overall auditing for 2024, this is something that we've never done, which is kind of like a recap, a year in review. So we just wanted to take a look back at 2024 and see where everyone kind of fell. So this is a de-identified slide here. So you know your scores from your overall chart audit that we did for you in 2024. So you can find yourselves on this little map to see which CMA you are. The one thing I will say is that if you have had your post-audit meeting in the last 4 to 6 weeks and you have sent us disputes and your score was increased, they're probably not reflected on this graph because I made this graph at the end of December once we had all those preliminary scores in. So a couple of you might be higher than shows here on this graph. But overall, our overall CMA audit score was an 86. So that was our average. That was our average adult enrolled in this program. If we audited their record, they received an 86. So you can kind of, in comparison to your overall score, kind of figure out where you fell. That red line across the top, that's our 85% threshold. So if you see that, anybody above that or at it is meeting health home standards. And then if your CMA is below it, then you are not meeting standards. And this graph is specific to our adult population. You can go to the next slide. This graph is specific to our children's population. So again, you see the de-identified CMA is on there. And then that red line going across, that's our threshold of 85%. So any CMA is at or above that is meeting our standards when it comes to auditing, and everybody below that is working towards it. So again, de-identified, you know your overall score for kiddos. So that would tell you what CMA you are on here. And our average CMA audit score was a 76. So any kiddo on average came out to be about a 76. So as you can see, there's a pretty big disparity between adults and children. Children require a lot more assessments, more paperwork, more nuances, more to audit. But we're really working towards increasing those scores. Travis, if you can go to the next slide. Working on increasing those scores because as you can see, this is our redesignation target here. So we received an 86 overall internally on our records, but really we were able to really bring that score up because of our domain 1 in our redesignation, which bumped us into that 3-year piece. But if you look at our kiddos, we are falling very below that. Again, our domain 1 will kind of bring us up. Our domain 2, we performed excellent. We were the best in out of all the children's health homes last time when we had our redesignation. And for those who don't know, domain 2 is your kind of your gaps in care. We were phenomenal at that for kids. So that should help bring us our audit scores. And audits count this time around for 60% of our score. So it's weighted 60%. So really into 2025, gearing up for our redesignation for children, we're going to have a big focus on increasing those scores all around because it will account for 60% of our overall score. Does anybody have any questions on that? We are going to move into themes that we saw in our audits next. All right, so I'm going to punt it over to Taylor, who's going to take the adult themes. And as we met with you to review your 2024 audits, we said it's not just you. Everyone struggles with this. When we had those meetings, we're going to kind of go through the highlights and what we saw in all of our audits as areas of improvement across the board. So Taylor's going to walk through all of those adult ones for you.
Oh, Tanya had a question, Jess.
Oh, I'm sorry.
Hands raised. That's okay. Go ahead, Tanya. Or maybe it was a rogue hand, I'm not sure.
I did not mean to do that. I'm sorry. As you said that, I said I did.
Rogue hand.
Sorry.
Yeah, that's all right.
Maybe I didn't take
No
it down from
worries.
before.
I don't know.
Sorry.
It just
Lowered
popped
her
up, so I
hand.
was like, oh, well. Okay. Let Jessica have a little break from talking and move into the adult themes, and then I will send it back over to her for the children's themes after. So like just said, as we move through doing your comprehensive chart audit review meetings, we let you guys know it was not just your CMA. These were the overarching themes that we found as we were doing the chart audits across the whole network. So I'll just briefly touch on these. That way you guys are aware. Forms, this was a huge one across the network. Making sure that all of your DOH forms are completed correctly, updated as needed, and uploaded in their entirety. So making sure that pre-filled entities have initials next to them, making sure that every line on the DOH 5055, the DOH 5234, the DOH 5235 is filled out. DOH will not give us credit if the form is filled out incorrectly. They basically say that it's not there. So very, very important as you guys are, you know, obviously putting in a lot of effort to get these forms and consents done with the members, making sure that it's completed correctly so that you guys are getting credit for all of your hard work. The eligibility screening tool, this is another big one, making sure that it is completed correctly and that it matches the uploaded supporting documentation and problems list. So it's very important that all three of those things match. If you mark that you're on your eligibility screen that you're enrolling your client through 2 chronic conditions and we check out your problems list and there's only 1 problem on there, that's a red flag. We want to make sure that all 3 of those things match, and then that supporting documentation is matching the problems list and the eligibility screening as well. Health Home Plus documentation needs to be uploaded and needs to be supportive of the billing category that you're selecting on the HML. So every month you guys are selecting what you are billing Health Home Plus for. If you're billing Health Home Plus for criminal justice involvement, we want to see that criminal justice involvement supportive documentation uploaded in the chart versus, you know, say like a SPOA or something of that sort. We want to make sure that whatever documentation you have in the chart is the reason why you are billing and vice versa. Needs, just kind of touched on this earlier, but making sure that the needs on the comprehensive assessment are addressed in the plan of care. And if not, there is a note correlating to that date as to why they're not being addressed. All plans of care need to have a signature, ensuring that even those amendments are getting signed and uploaded into the chart. For our HARP members, we need to make sure that we are having a documented discussion about those HARP and core services. Just making sure to note that. We will have a couple of slides later on in the deck related to this, so I won't harp on that too much. Travis, you can go to the next slide. Sorry, that was so lame, but that's okay. Monthly care manager note, another thing that Jessica had mentioned, ensuring that you are addressing the items on the plan of care through that care manager note. So something important to note, you know, obviously our contact notes are billable, but if you have something that you're working on with the member month over month, you might want to consider adding it to your plan of care, doing an amendment, adding it in there. That way you can use that monthly care manager note to address that item on the plan of care. Like Jess said, it is kind of the driving force behind everything we're doing. So we want to make sure as DOH had updated that plan of care policy that we are doing that monthly care manager note and addressing those items on the plan of care. Next, if the member has an ER visit, inpatient stay or admission, that the care manager reaches out to the member to coordinate care or reaches out to the hospital staff to support discharge. Like Jess had said, due to disenrollment, if you are disenrolling a member, all of them need a discharge plan and a discharge letter. And then if you are issuing the 5235, it is done correctly and within the correct time frame. So you want to make sure that you are issuing that 5235 at least 10 days prior to the member's disenrollment. And keep in mind too that there is guidance that says that it is based on the postmark date. So keep in mind, you know, how your office, how your agency does their mail. You know, if it gets picked up every day, you're probably fine to stick with that 10 days. But if you know that the mail only goes out once a week or every 2 days, you may have to adjust when you're sending that to make sure that you're getting it out at least 10 days prior to that discharge date. And then lastly, all members who are disenrolled, the care manager must notify the care team that that member is disenrolling from the program. Any questions on any of the adult themes? Okay, sorry, Jess, passing it back to you.
That's all right. I'm back. Okay, so we're going to go over themes that we saw in our children's audits and in our HCBS audits. So forms, much like the adult side, we need to make sure that all of our forms are completed correctly and updated as needed. Especially that 5201 and that tracker, they all have to be completed and updated. The tracker is going to have to be updated at birthday if they are turning 10 and they have any of those services, or turning 12, or updating the 5201 section 2 to include that. Another big thing is there has to be a note in the record indicating that the care manager reviewed the 5201 FAQ with the family prior to them completing the 5201, and also that we asked to speak alone to complete section 2 of the 5201 with the youth. Anybody who has not been meeting this standard, I've really encouraged them to have a kind of standard intake note that they can just fill in the information, but it ensures that they are touching on those two things. These are things that once you've missed the mark, we cannot go back and correct. They're going to always be wrong moving forward, unfortunately. So it's super, super important that we get it right at intake and then moving forward. Another thing that you have to make sure that is correct from the go, and there's kind of no going back and correcting it, is that if you accept a referral on the kiddo side, you reach out to the family. You have to reach back out to the referral source to let them know the outcome, saying like, hey, I left the family a message. Oh, I talked to the family, they're not interested. Oh, we have a scheduled intake. I called them and they didn't answer. Whatever it may be, there has to be a reach back out to that referral source and then the outcome in that note. And unfortunately, if you kind of miss that in the beginning, we can't go back and correct it. And then much like the adult side that Taylor touched on, your eligibility screening tool has to match your uploading supporting documentation that has to match your problems list. All three of those pieces have to be correct. They all tie to billing, and they're all telling DOH that you are billing for this member for this reason, and you have the documents for that reason to bill. So it's super, super important that all three of those things match. Also, just like on the adult side, any assessments that have needs are tied into the plan of care. And if they're not tied into the plan of care, that there's a note as to stating why they're not tied into the plan of care. And then again, signatures 10 and older. Anybody who is 10 or older in Children's Health Home, we need a signature on their plan of care from the youth and from the medical consenter. If the youth refuses to sign, you just make a note and then you have the medical consenter signature on there. You can go to the next slide, Travis. Risks. If there are risks or safety concerns that are noted on the safety and crisis plan or in the risk sections of the comprehensive assessment, we want to make sure that those are included in the plan of care. So if you have a member on the risk section, also in the CANS, it's noted that they self-harm. There should be a component to that addressed in that plan of care. They have to tie together. If there are any sort of crisis event that occurs, an ER visit, an admission, we have to be referencing the safety and crisis plan. So either that's you reviewed the safety and crisis plan with the member, after an ER visit, it's still appropriate, no updates needed, or it's not appropriate and we do need to update that safety and crisis plan. There has to be some correlation to that. So I highly recommend that anytime you have some sort of admission, ER visit, crisis, you do your follow-up, because you have to. After a Hallmark event, you do your follow-up. Directly in that note, you reference that safety and crisis plan. Another thing that's kind of newer, but not really newer, it was just there's been some clarifying language over the past probably 18 months, is that when you're completing a CANS, they're really looking for evidence that you have documentation to support your CANS ratings. So that could come with the referral. It could come with you collecting your eligibility documentation. It can come from, you touching base with the school as you formulate your care team. There has to be some sort of note or some sort of documentation that shows and demonstrates that as you went through and did your cancer ratings, it didn't just come in isolation with you and that family member and the medical consenter. Again, as I addressed it earlier, with the plan of care, anybody who is 14 or older or 17 and older, you have to have goals in your plan of care related to living independently or transition to adulthood. Those are two important required components. In that we have to be recording our interdisciplinary team meetings in the interdisciplinary team meeting form in NetSmart. That is how we demonstrate that those meetings have actually occurred. You can go to the next slide, Travis. Next, if you have a member and they're enrolled under a single qualifying diagnosis of SED, you have to have an attestation on file within the last 12 months. To be enrolled in Health Home under SED, it is not just a diagnosis. It is the diagnosis plus the functional limitations. Then you have the designation of SED. So that form, if you enroll somebody in Health Home for that single qualifying reason, you have to have that form at enrollment, and then you have to collect that form every 12 months. So that is something super important to keep your eye on if you decide to go that route. Otherwise, go chronic condition, because more likely they have more than one diagnosis, so you can go chronic condition. This would just be super important to pay attention to if you have any youth that is accessing HCBS or any youth that is accessing high fidelity RAP or will be, then you'd really want to make sure that you're demonstrating that they have an SED diagnosis, because that is a prerequisite for both of those programs. I said this earlier, anytime, again, there's an ER visit, inpatient stay admission, care managers reaching out to kind of follow up on that, coordinating as necessary. Another thing would be all disenrolled members are going to need a discharge plan and that discharge letter. That's one of those things that the state noted on our EOP, something that we noted on the adult side and also on the children's side. Again, the 5235, if you're going to be issuing that form, because it's needed, you want to make sure it's completed correctly, and it's issued within those required timeframes. So just like Taylor said, they're going by the postmark date now. So if you know that your mail only gets picked up once a week from your office, you may want to adjust when you are sending that 5235 out to make sure you do have those 10 full days. And then anybody who is disenrolling, again, you have to notify the care team of the disenrollment. Like I said, internally, we use a letter. You guys can use whatever modality of notification that you would like. Again, if you'd like a copy of that letter, we can get that over to you. So those were major themes for, we'll call it mainstream Health Home for children. Does anybody have any questions on that? All right, so I'm going to move into, you can go to the next slide. I'm going to go into children's HCBS themes. This is super important that we're talking about this here and we're addressing it here, because for redesignation, there was a modification on how we're designated. We've talked about that for over a year with you guys, but one of those things on the children's side, they will incorporate our HCBS scores into our redesignation. And that's important because we are not performing well. No one in the state is really performing well. So, you know, take it for what it's worth there, but we're really not performing well. So it's really important that we let you guys know what's really important on our HCBS audits and what we're seeing across the board, so we can kind of all work together to work on increasing those scores. So some stuff that we noticed on our HCBS audits in 2024 is that first and foremost, subprograms have to be entered into NetSmart and then ended in NetSmart when your HCBS program is ended. That's super important to track this population. The other thing that we have noticed is that anybody who accepts a referral for HCBS on an HCBS member, and that member is coming from CS, in one of your first intake notes and conversations with the family, we have to be noting that we spoke to that family about the differences between CS and health home. There are differences. They should have been discussed before that person chose to go to health home, but we have to reiterate those differences. And on our audits, they are looking for that very specific conversation. So just keep that in mind anytime you accept a referral from CS. Again, back to that SED attestation on file incorrect. Anybody who is enrolled under the target population of SED, so this is just for SED folks out there in HCBS, you have to have that attestation and it has to be within the last 12 months. You're going to have to get a new one every 12 months. You also want to make sure it's correct. Just because a clinician is giving you a piece of paper does not mean that they've completed it correctly. You want to make sure that the diagnosis on there is an SED eligible diagnosis. And you can see that in our policy. You can cross-reference that. And if you're unsure, you can always reach out to us and we can double check it to make sure that it's correct. I'm going to double check it anyways, because you're going to have to submit a form to me to review before anybody does an initial level of care or anyone does an annual level of care. That is one of the things that I check. The other thing, you want to make sure that your LPHA is completed and that's also completed correctly, and that you have supporting documentation on file for the risk factors that are in your LPHA. That is super important. If you were telling the LPHA that this member needs HCBS, because in the absence of HCBS, they are at risk of being removed from the home, and that is because they've applied for an out-of-home placement, that documentation has to be in the member's record. There also has to be a documented conversation that the care manager even discussed HCBS with the family. They've said, hey, we're going to apply for this, or this is what it is. And I think about, moving towards a level of care. Sometimes we just see that HCBS appears in the record and there's no real documented conversation that care manager had with the family. So that's something that we're looking for. When a family, goes through this process and they select certain services, those services and those referrals have to be made in IRAMS within 4 days of selection. So that's really important. If I'm noting on this day that I had a conversation with this family and this family said, I'd like to receive pre-vocational services within 4 days of having this conversation, I have to have those referrals in IRAMS. And yes, they do check the days when we're audited. So you want to make sure that you're prepared when you go in to have those conversations, that you have the time blocked off on your calendar to get into IRAMS to make those referrals. Once you have a level of care completed, you have to issue the notice of decision, that 5287, and that freedom of choice form 5276. We have 3 to 5 business days to get those forms completed, discuss them with the family, and have them uploaded into the record. Again, so if you're going to be completing a level of care, you want to make sure within the next 3 to 5 business days, you have some time blocked off on your calendar that that you have to call X person's medical consenter to meet with them to review these forms and issue them and review them. You can go to the next one or the next slide. So also with the freedom of choice form is rights and responsibility sheet. It is not part of the freedom of choice form. It just accompanies it. It is super important that either you have this sheet that you are reviewing with the family and they initial it and you upload it to show acknowledgement that you reviewed it, or there has to be language in your notes that you reviewed the rights and responsibility sheet and educated that family on how to report abuse or neglect by a service provider. This is language that they are specifically looking for in our records. If you have an HCBS plan of care, it has to be you have to complete an HCBS plan of care within 30 days of a finalized level of care. If your member is coming to you with an active level of care, you do not have 56 days to do a plan of care. You only have 30. They're very, very, very strict on those 30 days. It is 30 calendar days, not business days. So if your, let's say, 30th day is on a Saturday, it has to be done the Friday before. Those timelines are very strict and there is no wiggle room for that. And then as you do your plans of care for HCBS, there has to be at least one goal and one intervention of the HCBS service. That is a requirement of HCBS. It's something that we look for when we audit. It's also something that they look for. We do have a whole HCBS plan of care training where we go into more detail on that. The other thing is monitoring HCBS services. There has to be one note per month showing the oversight of services or addressing barriers to services. Even if that member is just sitting on a wait list somewhere, you have to show actively once a month that you are monitoring that. And then your recertification for HCBS has to be done every 365 days. That member's level of care is only good for 365 days to the date. On the 366th day, the Department of Health is going to remove your K code for that member automatically. So it's super, super important that those are done on time. And then also with any disenrollment, you want to make sure that you complete the forms, that they're completed correctly, and that they are uploaded into the member's record. Again, a lot on HCBS. It's going to be, as we move into 2025, an even more enhanced oversight of this population and our kiddos, because we are moving into redesignation time for them. Does anybody have any questions on that? All right, you can go to the next slide, Travis. Okay, a couple quick things that I want to touch on, and then I promise everyone can get out of here. MAS. We've been hearing a lot about MAS issues. One thing that I ask, and you can bring this back to your teams, that if you are having issues with transportation and cab companies are not showing up or canceling rides, and it leads to an increased cost in care for that member. So let's say that that member is supposed to go to the doctor's appointment, the cab doesn't show up to pick them up, they miss their doctor's appointment, and then 2 days later they're in the ER for something. I'm going to consider that an increased cost in care. If you could report those directly to me so I can keep track of them, and then I can go to the managed care companies with these concerns. We've had a lot of issues. We've tried to work with MAS. We're not really getting anywhere with them. So my next step is going to be going to the payers. But I do need some specific examples of this happening. So I just ask that if you do see this happen, if you could just please shoot me an email with who the member is, what happened, and that I will do my best to escalate this up. You can go to the next slide. Eligibility documentation, I just wanted to put this out there just because, as you all know, we're going through that OMIG audit right now. When you upload supporting documentation for eligibility, want to make sure that there is some sort of date on that. So if you do a psyches printout, there's a date on it. If you have, a problems list from the last visit, there's a date on it. For the most part, there's a date, but there is some circumstances when we're uploading supporting documentation that there's no date on it. And what OMIG is telling us is we have no way to prove that that service that we delivered was delivered at a time when we had confirmed eligibility for that member. So just keep that in mind as you collect eligibility. Just keep that in mind as you, take a look at your charts and you check that, just to make sure there's a date on your documentation as you upload it. Okay, you can go to the next slide. Okay, last, HCBS core form. I'm going to go through this quickly because we are running out of time. So this is going to be specifically for our adult population. Earlier, Taylor had mentioned that one of the things that we need to work on, one of the areas of improvement that was identified by the state, is really making sure that we have documented conversations with all of our members who are HARP, have that H code, about HARP and core services, and that they are educated on the availability of those services. So we have added a form to NetSmart that moving forward, we're going to have anybody who has a HARP member complete. And then this will allow us to track better the conversations, the outcomes, and it's reportable. So eventually it will be built in DataDen. So on the bottom left-hand corner, you're going to see the HCBS core services tab appear. It will look like this. That is what you're going to click on for any member that you have that is HARP. And then that is where you're going to track your conversations about HARP and core services. You can go to the next slide, Travis. So this is what it looks like. This is what it's going to look like in NetSmart. Basically, finalize it, always finalize everything. It's just going to say, okay, what is the code that this person has, just to confirm that the code is there, the date identified, just the day that you confirmed that they had that H code. Are they interested in core services? Yes, no, yes, complete the thing. If it's no, totally fine. And then there's that little button there that says add core service. You can add a second one if they're interested in that. Go to the next slide, Travis. And then interested in HCBS, yes, okay, fill it in. No, it's completely fine. And then any comments at the bottom, pretty straightforward. It's just a place to record those conversations. We are going to be updating our HARP policy. And then I'm going to be having a HARP core kind of like overview for care managers where we'll discuss this new form. So right now the form is going to be deployed as optional. Once that policy is updated, we are going to ask everybody to utilize this form, which will allow us to better track these conversations. And we can report out on them to DOH for redesignation and to our MCOs because they often ask us this information. And as you well know, we then send it to you and then you got to piecemeal it back together. So this is just going to be an easier way for us to kind of collect that documentation and make sure that we are meeting the state standards on having these conversations with our members. So that was a lot. That's our last slide from today. Does anybody have any questions on the core form, eligibility, or the MAS piece that I touched on last? All right, Travis.
Well, thank you, Jessica. Appreciate the overview, long overview today. Appreciate it. Just one last thing I want to let everybody know. So far, there is not any budget cuts for Health Home in the 2025 executive budget. So that is a huge thing for the Health Home community. So I just want to make sure for those of you that are not aware of that, that you are. So I just want to get that news out there to you. And if we hear anything different, we will make sure we let you know. But with that, thank you for all you do each and every day. And if anybody had anything else, please let us know. If not, I hope you have a great rest of your day. Thanks, everybody.
Bye.